Thank you everyone for joining us for the Asian Cardio-Oncology Society Conference Series. Without wasting any further time, it gives me great pleasure to introduce our two chairpersons, Dr. Shivaji Basu, Senior Urologist from Kolkata, and Dr. Anuprita Dadi, Consulting Physician from Mumbai. The first session is a paper review on the pronounced randomized trial. And with that, I request our chairperson, Dr. Anuprita Dadi, to please introduce our first speaker.
Good evening. Can you hear me?
Yes.
Yes,
Ma'am.
Yeah, good evening, everybody. Welcome for today's session. It's a paper review on pronounced randomized trial. I would like to introduce today's presenter, Dr. Ranjit Sahoo, medical oncologist from AIIMS, Delhi, to start with the session.
Are my slides visible?
Yes.
Yes, slides are visible. You're audible. Everything is perfect.
So, so this is the paper review that I'm going to present. This is the pronounced study. And at the outset, I would like to thank the organizers to give me this chance to present amongst this August audience. And I do not have any conflicts to share. So the concept is destabilization of the atherosclerotic plaque. Now, it is known that the T cells, they express this GnRH receptors. So, I'm sorry. So this is a GnRH receptor. So when we give a GnRH agonist, so it tends to make the T cells more active. So there is more inflammation, which destabilizes the plaque. And once the plaque is destabilized, it causes all the cardiovascular issues. So this is the paper which was published in Circulation in 19th October 2021. And this is the primary results, rather we should call it interim results of the pronounced randomized trial, which was supposed to include close to 1,000 patients, but because the accrual was slow and the results were not showing a great difference, so they have to, and it was a sponsored study, so they have to interrupt it before the final completion. So coming to introduction, I mean, atherosclerotic cardiovascular disease is the leading non-cancer cause of death in patients with prostate cancer. 2/3 of patients with prostate cancer, they have high cardiovascular risk. And almost a quarter, they have established atherosclerotic cardiovascular disease. However, it is very less known, I mean, whether the mode of testosterone suppression by an agonist, a GnRH agonist or antagonist, differentially affects the cardiovascular risk. In particular, among the patients who have pre-existing atherosclerotic cardiovascular disease. So this was an international multi-center prospective randomized. It had to be open label because both the drugs are, one is monthly, the other one is 3 monthly injection. And SAM injections were not that logical. So this study was to compare the effect of either GnRH antagonist, which is Degrelix, with GnRH agonist, which is leuprolide, on adjudicated MACE in patients with prostate cancer with established atherosclerotic cardiovascular disease. It was a sponsored study from Pharynx. So ASCVD was defined by either an history of MI, any previous revascularization procedure done on carotid, coronary, iliac, femoral, or popliteal arteries, previous documentation of stenosis of more than 50% in these vessels by either angiography or by carotid ultrasound, or presence of peripheral arterial disease demonstrated by a diminished ankle brachial pressure index of less than 0.9. MACE is a composite of all-cause death, MI, stroke. MACE is major adverse cardiovascular events. So they have calculated the sample size based on a retrospective study where the projections for Degrelix was close to 5% and 10% for leuprolide. So they have estimated a sample size of close to 900. But somehow they could not go up to the 900 patients because of the very slow accrual of this study. Now, this study is one of the first to look into the cardiovascular events by GnRH agonist and GnRH antagonist as a primary endpoint. This is one of the very first study. So let's come to the primary outcome of this study, which is the first adjudicated MES. As you could see, these two lines are completely overlapping. So there is no difference of the MES which is adjudicated by the physician to be confirmatory to be this is a cardiovascular event. And it is not different between a GnRH agonist and GnRH antagonist. And because most of the cardiovascular events were in the first 1 year of starting this hormonal therapies, GnRH agonist or antagonist, so they have taken it through the first 12 months. Now, the oncological outcomes, if you see, I mean, sorry, I have missed the table where they have the patient inclusion. They have included all sort of patients who require GnRH agonist or antagonist, be it localized, be it locally advanced, and in few cases, they have also included metastatic cases. So coming to the oncological outcomes, the progression of disease while on GnRH agonist or GnRH antagonist, it is not different. As you could see, there were only in the first 12 months, there are 24 and 27 patients. The hazard is 0.89. And the castration levels as defined by less than 50 nanogram per deciliter by day 28, they have achieved by both these agents similarly. Sustained castration by day 336. It is also very much similar between the two arms. However, profound castration, which is less than 20 nanogram per deciliter by day 336, it is achieved by 80% of patients who received Degrelix, while close to 70% of the patients who received Leuprolide, which is statistically significant. Now, this is an old slide from the publication where it was shown that GnRH antagonist has got better cardiovascular safety as compared to GnRH agonist. Now, when you look into the multivariate risk factors, you could see that GnRH antagonist, they have a hazard of 0.438. It means it is, as compared to GnRH agonist, they are protective, and the p-value is significant. The use of statins is also very found to be protective, even though the p-value is not significant, which is defined by less than 0.05, it is just crossing 0.05. The use of alcohol use, and it is not very clear from this study whether it is mild, moderate, or severe alcohol use, but mostly they were pointing towards milder use of alcohol. It could also be protective on a multivariable analysis. The presence of hypertension, be it controlled or uncontrolled, it poses a higher chance of having a cardiovascular mortality. However, at the same time, those patients who have got cardiovascular mortality, smoking doesn't increase the incidence of cardiovascular event in a multivariable model. And same for serum cholesterol, same for having diabetes, same for whether hypertension is treated or untreated, same for whether when age is taken as a continuous variable. The baseline testosterone level was also found to be protective towards the cardiovascular risk factors. And the baseline BMI, whether they are obese or not obese or as a continuous variable, it was not found to be significant. Now, this multivariable analysis was only done in patients who have got baseline cardiovascular risk factors, not in other patients who do not have the cardiovascular risk factor by the definition. This study was done by Albertson et al. It was published in somewhere around the mid-2000s. And the current study that I was discussing, it was somewhere around 2008 to 2010. And within this time period, a lot of things have actually happened. I mean, the oncologists, they have understood that the cardiovascular mortality in such cases are high and how to actually take care of it. So this study, I was not surprised, and this is not a very good study. Had this study been complete by all aspects, and then we would have known for sure that between these two agents, none is better than the other with respect to the cardiovascular outcome. So my take in this study is, now it is very difficult when you get a retrospective observation by doing a retrospective analysis and you want to prove it in a prospective manner, because the whole game changes here. Because most of the practice changes, they happen on the basis of retrospective analysis. And when by the time you go down, plan a prospective study and start accruing patients, many of these things are already changing. And this study is inconclusive due to various reasons. They took the sample size from a retrospective design, not from a prospective analysis, one. And then this study has to be curtailed in the first interim analysis. And I feel the gap between the first retrospective, for the first publication and this publication, there was a lot of awareness. So the involvement of cardiologists and other they were much more involved in taking care of such cases. And it is also important who is running the trial. Now, this trial was run under the cardiologists, and that's why we could not find a difference between leuprolide and this thing. I didn't show it in a table, but the number of protective cardiac medications, they were used quite a bit in this study population. So when the cardiac events are not independently confirmed, so when physicians, they confirm the cardiac events, the numbers will look something like this. Now, this number I have taken from the HERO study, which compared the outcome between relugolics and leuprolide. So cardiovascular outcome was a defined outcome, but it was not a primary endpoint. So the incidence of MACE with relugolics was 2.9% versus 6.2% in leuprolide in patients who have got at least one cardiovascular risk factor or history of cardiovascular event. Now, when this study looked into using a similar definition, there was actually a benefit towards degarelix, but this was not statistically significant. And as I told you, because the numbers are actually shortened. So even though this is a key secondary endpoint, we could not find a significance in this analysis. So I would also say that with time, we understood that this cardiology care of prostate cancer patient is essential, and it should be done in a very nice manner, and they should be included into the management of such cases very early in the management. So my last words will be, in the real world, which I would say, you could look into many studies of degarelix, though there are clearer negative studies which are also supporting that leuprolide is almost as safe as degarelix. I would say the cardiovascular safety of these two medications, be it degarelix or relugolix, it is still there. So I would have a bias to suggest this medication to patients who could afford these drugs and those who have got cardiovascular risk factors. But in ideal world, where everyone is involved and cardio-oncology is a defined discipline, it's just about flipping a coin, I would say. And a bias will be towards an agonist because they are better drugs, unless relugolix is available at a friendlier price, which is an oral drug. So that might change the game a bit. So that is my last line. Thank you for the kind listening. I'll be happy to answer a few questions with permission.
Thank you so much, sir. I believe Vivek sir has a question. Vivek sir, please go ahead.
Yeah, Ranjit, quite an interesting take on this study. And just as you said that, reviewing this study and many others, ultimately, I think, it all comes down to cardiovascular care. And just as you said that, if the cardiovascular care is good, probably leuprolide is equal to Degarelix. But if the cardiovascular care is not good, probably Degarelix may be more safe as compared to leuprolide. So this is what you sort of want to suggest, that if the oncologist or the urologist has a good cardio-oncology support, if has a good cardiology support, then maybe they can go on to choose leuprolide, because the patients are more compliant and they are more following their own cardiologist, taking care of the cardiovascular risk factors. And in those patients whom we think that they are not that compliant, or they are not that careful about or where the cardiovascular risk factors are lesser, probably there we could go to a more purportedly cardio-safe molecule like Degarelix, because we must draw a conclusion as to, and I'm sure there will be discussions in the panel discussion as well.
Yeah, so I completely agree, sir.
So do we have any other questions from our audience?
Yeah, Dr. Shivaji and Dr. Anuprita, if you have any comments.
Yeah, I feel that the results of this trial also should be taken cautiously, because they contained 90% of the population was white population. Whether this results could be applied to our population is also a question. And as Vivek said, it should be under cardiac monitoring, close cardiac monitoring. We can go ahead with this kind of treatment.
Yeah, I agree on that one. I think that is the basic which came out from all the pitfalls and the other things of the study, that the cardiac care is important. It will improve the results, whether it's an antagonist or agonist. So that's a march. And that's why probably the American Association of Urology, and this 10 years back, they did the pool survey and the advisory that all together, all three specialties will obviously work to get a better result. So ADT or non-ADT treatment, antagonist and agonist, these are questions will remain unanswered for some time. So we take as it is coming there, but the cardiac care is important. There is no doubt about that. That will improve the result. Thank you.
Thank you so much, sir. If we don't have any more questions, we can move on to our panel discussion.
Yeah, sure, Kashish. Let's go ahead and start the panel discussion.
Perfect, sir. So it gives me great pleasure to invite our chairperson for the panel discussion, Dr. R.K. Gopalakrishnan, a senior urologist from Kolkata. And now I invite sir to please introduce our moderator.
Yes, our moderator is Dr. Deepak Dabkara. Dr. Deepak Dabkara has made a very good name in Kolkata, where he started his urological career here. And over a period of few years, he was a very well-known person on most uro-oncological panels, because of the clarity of his vision and the clarity of his thought regarding most uro-oncological subjects. Now he is in Indore, and I invite him to be the moderator for the session.
Okay. Thank you, Dr. Gopalakrishnan. And I will invite the panelists. Dr. Ganesh Bakshi is a urologist, uro-oncologist in Hinduja Hospital. Dr. Amit Joshi, Dr. Abhirup Guha, Dr. Shailendra Shakya, Dr. Vamshi Krishna, and Dr. Arnanshu Das.
So please note, Dr. Amit Joshi has not joined us. The rest of the five panelists have joined us.
Okay. Dr. Abhirup is there?
Yes, I'm here. Thank you for the invitation.
Okay, thank you. You are a medical oncologist or urologist?
No, I'm actually a cardio-oncologist.
Oh,
so,
sorry. Okay.
And I work with Vivek on sort of more of research initiatives. I'm located in the US, so I'm the director of cardio-oncology at Georgia Cancer Center in Medical College of Georgia.
Okay.
So it's been a great discussion so far, and I think I'm looking forward to talking to everyone. I'm just going to start that one of the things which Anuprita just mentioned was very important. I mean, all the data which comes from this part of the world and from Europe, I think it doesn't include the population which we take care of in India. So I think everything which you see should be taken with a grain of salt. I think the biggest take home from pronouns and from HERO is that when you add a cardiologist to the mix, it's very hard to do a study because your event rates in both arms become similar. So you cannot adequately power a prospective study. So that was the biggest take home. We recently had an medical advisory board for, it was a combined medical advisory board for Pfizer and Myovant. Myovant makes Relugolix. And that was the conclusion. That was the conclusion that, prospective studies are needed. But also sort of bring to everyone's attention, the European Society of Cardiology had the Cardio-Oncology guidelines. If you see the prostate cancer section in that, they did give a 2A level of evidence B recommendation for use of GnRH antagonist to agonist in patients with pre-existing cardiovascular disease. My personal opinion is kind of premature, especially for, again, the Indian audience, because none of these studies represent anybody we take care of in India or any of South Asia. So I think there's more to come in the space. But thank you for the
Thank you. And Dr. Vamshi is there?
Yeah, I'm there, Dr. Deepak.
Okay, Dr. Shakya?
Yes, sir.
Okay, you are a medical oncologist?
No, I'm a cardiologist.
Okay, thank you. Yeah. And Dr. Arnanshu Das is joined?
Dr. Das?
Yes, can you hear me?
So your volume is quite low. We can see you.
Yes.
Hello, can you hear me?
So we can hear you, but the volume is very low.
Very low.
Let me check. Can you hear me now?
Yes.
Very low. Yes.
Thank you.
Yeah, I'm an oncologist working at Dhaka, Bangladesh at a Square Hospital. This is my first experience with Asian Society of Cardio-Oncology. I've been introduced with Vivek long back, but never been a part of this society. So I'm really glad and happy to be in this webinar. So first of all,
thank you.
To say my experience, I would say cardio-oncology is a very new concept in our country, I mean in Bangladesh. So when we are using GnRH agonist, we never thought of it would have a cardiac issue. So Degarelix also came it's also a quite new drug. And we also have Relugolix here, but not yet that much popular. So cardiac issue related to GnRH agonist is quite new for us, but now it's emerging and we are discussing.
Okay, thank you. So we will go for the case discussion. So can you share my slides? Next slide. So this patient is a 60-year-old male. He has a history of lower back pain, increased urinary frequency, high PSA, bone metastasis, and there is no history of cord compression. He is metastatic, hormone sensitive, high volume prostate cancer. He is hypertensive since 8 years and taking some antihypertensive medications, and his BP remains around 140 to 150 by 90 to 100 mm. And he is diabetic on OHA since last 8 years. It is controlled. He has a family history. His father also had hypertension, and he's a smoker. Next. He's occasional alcoholic and not regular in exercise. And he has last seen his general physician 4 months back, and at that time BP was controlled. Next slide. So this patient is a high volume metastatic prostate cancer with the history of diabetes, hypertension, and he requires anti-cancer treatment. Next. So these are the options: androgen deprivation therapy alone, ADT with bicalutamide, with enzalutamide, Aberratron prednisolone, triplets, androgen deprivation with docetaxel with Aberratron prednisolone, and Relugolix with Aberratron acetate prednisolone. So we will not discuss about this, whether we'll use doublet or triplet, but we all know that androgen deprivation therapy alone is not a standard treatment as of now for a high volume disease patient. Next slide. So do all of us agree that prostate cancer treatment leads to significant cardiovascular toxicities? Dr. Ganesh Bakshi.
Yes, I mean, it does lead to, with the treatments discussed in the earlier slide, and we don't see them immediately. Probably in the next, say, 12 to 18 months, would see them probably more pronounced. And with patients predisposed, there might be a slightly higher chance. This is all what we know. Probably we should check all our patients in a more stringent manner, which may not happen today. But even I, as a surgeon, I also try, if I see these patients, and tell them everything right from diet, exercise to taking care with a cardiologist directly. Just a very short comment. The response which I get from the patient is, I have seen the cardiologist 6 months back and 8 months back, and quite reluctant. I mean, but we have to just push them on.
Yes, this is also means in practice, the observation is that if with any patient you ask that your diabetes is controlled, hypertension is controlled, he will say yes. When you ask that when was the last BP checked, he will say 6 months back. Or well, how much was the BP? So he says it was 140, 150. Some people even consider 160 also as a normal BP. So, and we know that about 80-90% patients, they have some cardiovascular risk factor, and about 20-30% patients, they already had a MI or some other cardiac disease. So next question is, choice of treatment varies in a patient who has a cardiovascular disease versus those who don't have cardiovascular disease. So Dr. Avirup Guha.
So I would like to sort of commend Dr. Bakshi. I think that's the right way of doing it. I think it also comes on later. So I think, the practice change where a cardiologist starts taking care of a patient with an oncologist is going to be very hard. Now, India has a big population, which means prostate cancer, which is the most common cancer in men, is going to be very big. You probably see hundreds of patients a week, if not in a few days. So when you see that and you expect cardiology to take care of them, then it might be a very hard ask. So what I suggest is, when you get PSA, which means they're going to get a blood draw, get the labs which you need to not have the patient answer the question. Get an A1C, get a lipid panel. If you're not convinced the patient has cardiac disease, and if it's easy to get a calcium score, I order a calcium score. And apart from that, your blood pressure in clinic, and then when they visit in a week after to go over the labs for standard oncological care, you would know if you ask them to measure blood pressure at home, they bring all the list of the blood pressures. You'll know if they have hypertension. You can easily answer those 3 questions or 4 questions without ever needing to have the patient say anything, because the thing is, history is always dependent on who's talking. So that's what a sort of a pragmatic way of approaching it is. As far as choice of the medication, as I said, we are not there yet. We cannot guide care based on a study which was underpowered to answer the question which is being asked. We should guide care based on oncological guidelines, which has thousands of patients in phase 3 clinical trials, which have shows benefit. So you go with the best treatment for the patient. Whatever is the treatment for cancer, for high volume prostate cancer, you go for that so that you have the max survival. We can take care of cardiovascular issues. What cardiologists are really good at is doing secondary prevention. We are very poor at primary prevention. That's why all these issues happen. We are very good at secondary prevention. So patient has an MI, they'll go to the hospital and they get a stent. So all of us know how to do that. The thing is, unfortunately, we should be focusing on primary prevention, which is very hard to get done, as almost everybody in this panel has said. So I would say, do the baseline labs like a cardiologist would do, which is just baseline, lipids, glucose check, and whatever it is to establish risk factors, and then just go with the right treatment. And then if something starts happening poorly with the patient, very quickly refer to cardiology.
Thank you. So the best oncological treatment should be given to the patient and take care of the cardiovascular complications. Next slide. And the selection of our treatment is based upon comorbidities, balance between toxicities, quality of life, and survival. Next. And this already discussed, atherosclerotic cardiovascular disease is the leading non-cancer cause of death in patients with prostate cancer. And about 2/3 of patients, they have high cardiovascular risk, and 1/4 of patients already have cardiovascular disease. Next. And my next question is, do we all send patients for cardiovascular assessment before starting anti-cancer treatment? So Dr. Shakya.
Here we are practicing that we send everybody to cardiologist before any chemotherapy or any anti-cancer therapy. What we do is we get a baseline metabolic profile. We do a lipid panel, we do their blood sugars, we do their uric acid, their thyroid levels, we do a baseline echocardiogram and ECG, and make sure, and if we have any doubts, if there are any signs that the patient may have cardiovascular symptoms, then we do an NT-proBNP, or sometimes even a troponin baseline level before starting therapy. And then we follow up on that after a few cycles. We follow up on that.
Okay. Dr. Ganesh, do you send all your patients to cardiologists before starting ADT or ADT with chemotherapy?
Actually, as Dr. Virup said, we had this protocol of actually evaluating with lipid profiles, 2D echoes and everything when I was at TMH. And I have continued that even when I have left TMH. But honestly, 60% of these patients do carry things with them, and they have not even reported to a cardiologist or a physician for the last 3 to 8 months. I mean, at TMH, we used to many times refer to Dr. Anuprita and Dr. Sheila, and things happen that way in India. I mean,
yes.
So we also do find a lot of HbA1c is high, but I think we do assess, Deepak, we do assess. Even
Yes,
surgeons like me assess, honestly. But I know a routine practice, I see many others who really don't bother about it, very honestly.
Yeah,
We
Dr.
should
Vamshi?
make it a habit, I think. And Amit has also joined, actually.
Okay. Dr. Vamshi?
So, Dr. Deepak, I actually have changed practice in the last 1.5 years. Again, with the more increasing knowledge, we do try to send to a cardiologist. And I'm lucky that my cardiology department is quite a big department, and we have people who are trained in cardio-oncology. So since then, we are sending. Because previously, I just used to send to a cardiologist who would probably not do much because they were not aware of the oncology part of the problem. So now that we have such cardiologists, we are sending more frequently. And again, coming back to the point you were making about, saying that they have seen their own cardiologist. Sometimes the hardest thing is to tell the patient, look, I know you're seeing a cardiologist, but this guy will look at it in a different way. Please consult this cardiologist also. That sometimes becomes a challenge. So community cardiologists are not really very aware of the cardio-onco part of it. So that's been my observation.
Yes. So before coming to this meeting, I talked to my friends who are cardiologists, and I discussed about that. Suppose I send a patient with who is receiving ADT. So what additional you will do other than routine care of diabetes, hypertension? So they were not aware. Some of them, they were not aware. They said that we don't know exactly. So this is, I think, cardio-oncology is the evolving subspecialty, and with time we will grow. Next slide. And NCCN recommends referral to cardiologists before initiating ADT in patients with a prior history of significant cardiovascular disease, and a multidisciplinary approach, including oncologist, cardiologist, and cardio-oncologist, and geriatrician is required. Next slide. So, Dr. Amit has joined?
Yes, Deepak.
Sir, can you enumerate the cardiovascular complications?
I think that will depend upon the previous, if the patient is already having a history of myocardial infarction and all that, definitely the chances of, with this, as we all know that with the blockage of the testosterone axis, and those patients who do not have a history, at least what we have observed that the lipid profile abnormality will evolve over time. The hyperglycemia, what we call as a metabolic syndrome. So now what we are doing all baseline patients, the baseline lipid and a sugar and HbA1c, and then 6 monthly or a yearly monitoring of these that we recommend. And we have seen that this lipid and sugar deranged in this patient on follow-up. So for a pre-existing patient with a cardiac complication, having some stunting disease and all that, then we refer the patient to our cardio-oncology OPD and then start the treatment. So this field is evolving very rapidly, in fact.
Next slide. So ischemic heart disease, hypertension, heart failure, QT prolongation, atrial fibrillation, LV dysfunction, myocarditis, pericarditis, cerebrovascular events, venous thromboembolism, plus because of testosterone suppression, central obesity, diabetes, sarcopenia. These are the things which can happen in a patient who is receiving ADT plus minus chemotherapy plus minus other AR targeted therapy. Next slide. So we come to the patient, 60-year-old male, hypertensive, diabetic, smoker, high volume disease. And these are the options for ADT, orchiectomy, GnRH antagonist and agonist. So in a patient who is already hypertensive and diabetic, which of these will be your choice? This has already been discussed, but again, we will discuss this. Dr. Aviroop, already discussed, but once again.
I think I'll pass this question to an oncology colleague, because I think I would let you decide first and then would do the ABCD approach alongside with you. So the ABCD is the awareness of the heart diseases. You know what the list which you presented in the previous slide is what the patient needs to be aware of. That's what we spend a little bit of time telling that. I believe all patients with cancer, specifically prostate cancer, are in my mind secondary prevention, because as many of our colleagues have said so far, many of them have heart disease which is unknown. So starting them on an aspirin is not a bad idea. So those are the two A's. The B is blood pressure management and biomarkers. And we have talked about blood pressure and biomarkers separately, but just to put it together, if in a resource-rich environment, you can get a BNP and a troponin baseline. The reason to get a baseline is if they're negative, it's very valuable, because if something happens during the course of treatment, you know that it's heart-related, because if you measure it again, it'll be higher. And you know that you have a clue already from before that it was normal. The C would stand for three things: cholesterol management, cigarette smoking or smoking cessation, and calcium score. And again, calcium score is a more resource-rich environment. If we are able to get that, that's great. You go in with the knowledge that the patient has pre-existing CAD. And you can take it further and make a bigger reason to why to refer to cardiology. Even a general cardiologist would then be, if you see a calcium score of 1000, you'd be like, I think I need to do something about this. Versus a cardiologist has no idea about cardio-oncology, they would, as you said, might not do anything. These for three things: diet, diabetes, and dose. So diet is here it's different from India, but the American Heart Association has a Life's Essential 8 now. It used to be Life's Simple 7. The Life's Essential 8 includes sleep as well. That's how it became 8. But the diet and exercise, which is one of the E's, so we'll not go to E first. But the diet, I tell them, eat what you eat already. Do not make drastic changes. I'm not, giving you a whole list of diet, but a diet which you can make slight change, like one item which you eat better every day, will make their overall diet, because prostate cancer patients live for 10, 15, 20 years. That small change will go a long way over a long period of time. The other D is diabetes, and get a baseline A1C and manage it if you can. If not, they should follow with their primaries closely. The dose of the medicine, and that's where I think the research is going to come in the future, is if there is any change or escalation of dose or change of medication, like the questions you asked earlier, ADT, what ADT to select, which one not to select. We don't know enough to answer that question yet. The E is three things, which have been already said: echocardiogram, EKG, and exercise. The exercise, again, it's very easy to tell patients the whole AHA guidelines, 30 minutes a week, 30 minutes a day, 5 days a week. It's much easier to tell them, hey, why don't you walk for 1 minute more than you generally do? So that 1 minute over many years is a lot. And the thing is, when they come back next time, you tell them, since now you do 1 minute, you can down to 2 minutes. That small change is called atomic habits. If they make those small atomic habits over a period of time, they will make a lot of difference and changes. Eventually, they'll get to 30 minutes if, God willing. The other two things are EKG and echocardiogram. And again, that's very specific to specific agents. ARAs cause QT prolongation. So if you're going to use ARAs, you need a baseline QT. The other agents don't tend to do as much. If you're going to use Zytiga, which is more of a steroid type of agent, or just use steroids, then you need a baseline echocardiogram to show that EF is normal, the patient doesn't have diastolic dysfunction. But those are two things which are optional. I think doing the rest of them will help the patient a lot. So that's sort of my ABCDE for prostate cancer, which I follow, which is quite pragmatic, and you can change it based on circumstances.
Thank you. Next slide. So pre-existing cardiovascular risk factors, they are associated more cardiovascular toxicity. And so this already we have discussed. What are the minimum baseline investigations to be done for this patient before starting treatment? Dr. Vamshi?
Yeah, Dr. Deepak.
This already some part has been discussed. Next slide.
Yeah. So you're asking me the answer for this, or?
Yeah, please tell.
Yeah. So again, I usually nowadays would just send them to the cardiologist to start the investigations. If we don't have that follow-up, at least a 2D echo, at least an ECG. I'm not sure NT, BroBNP and all, how much they're useful in such a scenario. Definitely a good cardiac history as to whether there was any history of, a cardiac evaluation done previously. Honestly, I don't check for the ABPI and things like that, though, that's one of the cardiac risk factors that was included in the even pronounced trial. So I don't do that. And there are some cardiovascular risk scores, which ideally we should be evaluating for everybody. But usually I don't do it in practicals.
Next slide. So this is lipid profile, blood sugar, echo, ECG, and troponin and BNP. I've read about this before this presentation. So if BNP is high, throughout the means when you have started treatment, and after that also BNP is high, it indicates that there is a high chance of heart failure at some point. Am I right? If BNP remains high throughout the treatment of ADT, then there is a very high chance of heart failure.
I think the cardiologist should take that.
Yeah.
So I think this will go a little bit away from this discussion, but just in order to keep it short, heart failure has the different stage A, stage B, stage C, and stage D. So when you see a high BNP and you automatically by reflex most likely will get an echo. The echo looks normal, all parameters are normal, and BNP is just high. That is your type A heart failure. There's for some reason their BNP is high. So that may be an actionable item, and a very astute cardiologist might start them on a medicine for blood pressure management, even though their blood pressure might be 120, 130, 125. So I think just the BNP high with no other indication of any other pathology is a type A heart failure in my mind. Patient at risk for future heart failure, like you said.
Okay, thank you. Next slide. So this I'm not discussing echocardiographic, 2D echo, 3D echo, cardiac MRI, or some other tests. Next. But echo is less sensitive in detecting subclinical heart failure. And Joint American Heart Association and American Urological Association Committee, they had advised increased incidence of diabetes and major adverse cardiovascular events are associated with ADT, but there are limited prospective evidence to guide CV monitoring and management protocols in men who are receiving ADT. Next slide. This already we have discussed: awareness, blood pressure, cholesterol, cigarette, smoking cessation, diabetes, diet, exercise. Next slide. This also we have discussed: antagonist versus agonist. Next. So there is a meta-analysis of 6 randomized control trials, which shows that GnRH antagonist is associated with decreased cardiovascular events. There is one study in pre-existing cardiovascular risk factors, 700 patients, that also shows that antagonist is associated with less cardiovascular events. There is a phase 2 study which shows 20% cardiovascular events with agonist and 3% with antagonist. Next. Then there is this pronounced trial which we have discussed. Unfortunately, because of slow accrual, we could not get the clear answer that antagonist is better or agonist is better. Next. And this study, hero trial, relugolix, for men with pre-existing cardiovascular disease, the incidence of adverse events was 3.6% versus 17.8% with GnRH agonist. Next. So once we have started the patient on ADT with, for example, chemotherapy or Aberratron Acetate, it's a high volume disease patient, and baseline investigations we have done. Now, how frequently we will do ECG, echo, lipid profile, BP? Anyone can take this question, Dr. Aviru?
I think you do not need to repeat any of the imaging tests unless there is a reason to clinically. You would repeat tests for lipids and blood sugar based on what baseline findings you get. So there's we don't have solid evidence that we need to do more than once a year like you would do for your primary care, unless your other labs suggest, for example, if you get a BMP to monitor their toxicity for other reasons, and you show that blood sugar is always high, that might be a reason to check an A1C again. more sooner than a year. So I don't think so we have data to suggest that we need to keep doing it sooner. If you're managing them, obviously you'll have to do it sooner, like the guidelines for diabetes management and lipid management.
Okay, thank you. Next slide. This already you have discussed. Patients receiving anti-cancer therapies known to be associated with cardiotoxicity should be considered as stage A heart failure, which means that there is no structural heart disease or symptoms of heart failure. Next. So this Aberratron acetate prednisolone, either alone with ADT or with docetaxel, is a standard treatment, doublets versus triplets in high-risk disease. So can you enumerate the complications, cardiovascular complications of Aberratron acetate? Dr. Amit?
Yes, so I think the most important what we have seen is the rise in the blood pressure, the hypertension, which we tell the patient to monitor at least 2 weekly, at least in patients who are pre-existing hypertension. And the other thing which we have seen, the cardiac failure, though not very common, but occasionally we can patient presenting with whether it's a drug which is Aberratron it is causing, or it's the intrinsic region for that, or it's the ADT, we don't know, but definitely we have seen the cardiac failure, and sometimes a subtle cardiac failure from the leading to the bilateral pedal edemas, and sometimes frank heart rate presenting with difficulty breathing, and rarely some sort of atrial rhythm abnormality, that like atrial fibrillation, that what we have commonly rarely see in a patient on Aberratron prednisone. But hypertension, cardiac failure, and arrhythmia, which we can see.
Next slide. So this is from the product monograph. Use of Aberratron with caution in patients with a history of cardiovascular disease, and the safety of Aberratron in patients with ejection fraction of less than 50% has not been established. Control hypertension. Most common complication of Aberratron is hypertension and hypokalemia, and monitor blood pressure, serum potassium, and symptoms of fluid retention. Next. This is from Latitude trial. Hypertension, all grades 37%, grade 3 30%, hypokalemia, grade 3 10%, cardiac disorder 3%, atrial fibrillation 1%. Next. And this is death because of cardiovascular problems. Acute coronary syndrome, MI, AV block, cardiac failure, cardiac arrest. Next. CCF, MI, cerebral hemorrhage, CVA, and 10 patients in this study in Aberratron prednisolone group. There were 500 patients. 10 patients died because of cardiac disorder. Next. Enzalutamide. Enzalutamide also causes cardiovascular events, but it lesser as compared to Aberratron prednisolone. There are various studies and meta-analysis which have shown that hypertension is the most common cardiac complication of enzalutamide. Previous study 13%, Enzamet 8%, and for non-metastatic disease, that study showed that acute MI, CVA, cerebrovascular hemorrhage, and ischemia, heart failure was 5%, and meta-analysis shows relative risk for all grade hypertension of 2.82. Next. So we come to docetaxel. Vamshi, do you think docetaxel is cardiotoxic?
So cardiotoxicity is not in the conventional form of causing a cardiac thing, but definitely it can cause some cardiomyopathy, some fluid overload. All those are well known. Again, it's not something which we have seen too commonly, but it can happen.
Yeah, while preparing for this presentation, I also read about this, and I was also not aware that docetaxel can cause cardiotoxicity. Next slide. So it's mentioned that it can cause heart failure, LV dysfunction. The mechanism is direct cytotoxic effect, oxidative stress, and endothelial dysfunction. Next. And docetaxel has many complications. One of the most severe is cardiotoxicity. Incidence of LV dysfunction and heart failure varies from 2.3% to 8%. And docetaxel may also induce or exacerbate MI with an occurrence of 1.7%. Next. Glucocorticoids, this already we have discussed. Induces cardiovascular risk factors, obesity, insulin resistance, glucose intolerance, dyslipidemia, and hypertension. Next. So we come to the conclusion. Clinical assessment of prostate cancer patients. Every patient should undergo a thorough clinical assessment before starting any anti-cancer treatment. Age, type of anti-cancer therapy, patient's current status and prior CV risk, other comorbidities and concomitant medication should be checked. Geriatric screening for patients more than 70 years of age. Current CV cardiovascular comorbidity should be optimally treated, and a regular cardio-oncology consultation is required. Next. Every patient should be screened for hypertension, dyslipidemia, diabetes or pre-diabetes, ECG and echo at baseline and before every subsequent treatment line. And if CV complications occur, the decision on management should be based on the cancer prognosis, life expectancy, and patient's preference. Next. Thank you. I think it was very interesting discussion, and I came to know many new things. Thank you.
Thank you so much, sir. Vivek, sir, with your permission, shall we move on to our interview?
Yeah. Let us start the interview, and I think we have Dr. Darryl Leong with us. Dr. Darryl, if you would, kindly introduce yourself to all of us as to in what setting you work and how you have been working in this field.
Hi, thanks very much for the invitation to join you. It's very kind. I'm a cardiologist at McMaster University in Canada. My interest in prostate cardio-oncology stems from a number of research interests. I was on the DSMC for the PRONOUNCE trial, which I know you've spoken about already, and I serve on the steering committees of a number of other large prostate cancer trials that are in development. I'm also one of the leads of a study which Dr. Guha is collaborating with us on, called Radical PC, and this is one of the largest prospective cohort studies of men with prostate cancer, and especially to address the issues of cardiovascular outcomes in this patient population. And so that really summarizes my interest in prostate cancer and cardiovascular disease.
Yeah. Dr. Darryl, since you already told us how you have been on the data safety and monitoring committee of the PRONOUNCE study, which we just discussed. So what are your views and opinions about the PRONOUNCE study and its slow accrual? What was the actual reason why they couldn't complete the study? And since it is still an incomplete study, are there going to be more updates that we are going to get on this subject?
It's a great question, and there are so many factors really that go into a study's failure. I think, in my personal opinion, a slow response on the part of the sponsor in particular to the initial slow accrual was one factor. Secondly, the eligibility criteria were quite restrictive and cumbersome and onerous to implement. And that was a disincentive really to recruit to the trial. And so I think those factors, amongst others, meant, as you know, that they could not recruit enough people and did not have enough participants to reach the study goals, if you like. My interpretation of the findings fall into one of two camps that exist. Some people feel that because there was no difference between the groups at the end of the trial, that really there was no benefit for antagonists over agonists. There was no evidence of that. I fall into the other group, which would say that this trial was very underpowered. And in fact, and unfortunately, we can really come to no conclusions from the trial. So a fairly large, expensive trial was conducted that does not provide us with the answers that we really need. And that's unfortunately my interpretation of the findings.
Yeah. Dr. Leong, when we were reviewing, actually, Dr. Ranjit Sahoo, who reviewed the study, had a very nice point to make when he told that it all depends upon who is running the trial. If a cardiologist is running the trial, then probably the outcomes are going to be different. And if the urologist is running the trial, then the outcomes are going to be different. And if an oncologist is running the trial, the outcomes are going to be different. Because the cardiologist was running the trial, he told that already a lot of cardiovascular factors were taken care of, which probably would have been missed, in the other setting. So, what are your opinion about this difference, as who runs the trial also affects as to what are going to be the trial results?
Yeah, it's another great comment. To be honest, I don't know the discussions that took place that led to the pronounced design whereby all the participants had to see a cardiologist. But clearly this is not consistent with usual care, and it's not feasible in the real world for every man with prostate cancer to see a cardiologist. And so I think that moving forward, we need to avoid trials that really are not going to help inform clinical practice at the trial's completion.
Okay. Dr. Leong, you just said that you have been associated with prostate cardio-oncology since very long. So how do you see the difference in the clinical trials that have been conducted since the last decade, and how do you see the trials proceeding forward as to so what is the difference between the earlier trials and the current trials, and how do you see these things moving forward?
I think the great difference is really awareness. I mean, the fact that we have a virtual meeting like this and at many other international meetings, there's a recognition of the importance of cardiovascular endpoints in cancer trials and vice versa, to be honest. And I think this awareness that patients are complex individuals, they can have more than one adverse outcome, and we need to understand all of these adverse outcomes in a context. That's really the advance that we're making. And I think it's a good one. It's important for patients.
Okay. So, Dr. Leong, it all comes to this final question as to that we have been, almost asking ever since the last decade or so, as to which is more cardio safe. Is it the antagonist or the agonists are equally cardio safe? And the same questions are persisting. So why do you think we have not been able to reach a consensus as to regarding this topic, and we have been discussing the same thing again and again?
This is an important question. I think the simple answer to why we keep having this debate is the appropriate and adequately well-designed trial has not been conducted yet. My hope is that some of the trials I'm involved with that I mentioned at the beginning will be appropriately designed and executed to be able to answer these questions definitively. I don't think we have done so to this point, which is why we continue to have these debates.
Yeah, so this brings us to this question which Dr. Purish Parikh have just asked on the chat box. Because if right now, if you were to be in control of the trial, so what inclusion criteria will you change so that we actually come to a reliable result to answer this question?
So our emphasis is really on doing simple trials that are easy to recruit for and not overcomplicating it. Because as you know, making it difficult for getting patients into a trial only increases the study cost. It reduces people's willingness to participate in the trial, and it means that there's a lot of difficulty in completing the trial. So I think when you do these trials, it is important to enrich, if you like, the inclusion criteria and have slightly higher risk individuals. So you may have, for instance, you may want to specifically look at older individuals with some degree of cardiovascular risk factors, like 2 or perhaps 3 baseline cardiovascular risk factors or established cardiovascular disease. But the key is really in the details, and the details should be not to overcomplicate the inclusion of patients, I think.
Okay. So, Dr. Leong, in your clinical practice, how do you guide your oncologist to, start the correct treatment in your patient, and how do you ask him to choose between the antagonist and the agonist? So, obviously, both are there to stay and both are there to be used in our patients. But again, how to select the antagonist for the patients and how to select, talking about cardiovascular risk.
Yes, so for many patients, we really actually, to be honest with you, leave the choice with the oncologist because we feel that there is insufficiently strong evidence to make an equally strong recommendation there. There have been only select cases where somebody has literally unstable coronary disease, and they're very, very finely balanced, shall we say. And under those circumstances, I can have discussions with patients to say, while the evidence is still unclear, I think there may be a role for adopting a principle of, well, there's no harm in using an antagonist. If there is some benefit, then perhaps it's going to be in your best interest to take it. So it's only a very small minority of patients where I actually do advocate for the use of an antagonist. And I caveat it to the patient that, number one, as you know, Degarelix is a monthly injection. And so the risk of subcutaneous side effects is going to be significantly higher than with most of the agonists. And number two, we remain a little uncertain whether this strategy is going to benefit them from a cardiovascular perspective. Of course, the advent of Relugolix offers a different alternative, and there are increasingly going to be different antagonists available on the market. So I think these choices are going to widen as we move forward.
Okay. And then there always remains the traditional surgical choice also, although it might be lesser used in the West. But how do you see that surgical choice of ADT as compared to the medical choice and the cardiovascular risks?
I mean, you're right. It's certainly very infrequently used in North America. I would say well less than, sort of 1% of individuals eligible for ADT will have surgical castration. Obviously, it's a highly effective means of achieving androgen suppression, but will not stop the extratesticular synthesis of testosterone either. And so additional pathway inhibition may be very relevant for these men as well. Certainly the observational data, as you know, suggests that surgical castration is equally associated with an increase in cardiovascular risk factors and potential for disease. So I think these people should be treated just as aggressively for their cardiovascular risk factors as people on GnRH agonists.
Yeah. Dr. Darryl, what are your thoughts about the ongoing other research questions in prostate cancer cardio-oncology? So leaving aside the traditional question in ADT, what are the other relevant questions that are being asked these days, and other important trials that you are working on?
Yeah, I think for us, physical frailty and other aspects of cancer survivorship are increasingly important. We see that in work that will, we hope, come out soon, that physical frailty is one of the factors that's really associated with poor cardiovascular risk factor control. We see in other patient populations, it's associated with a higher risk of mortality. And in fact, it's one of the strongest risk factors for death and poor outcomes that there is. And that applies across diseases and across different cancer or cancer types, etc. So I think understanding why people with prostate cancer get frail, what we can do to reduce their physical frailty, that's one active area of interest for us as well.
Okay. I think, we have already exceeded the time, and I must thank you for your cooperation and kind presence. If there are any questions from the audience members to Dr. Darryl Leong, if anybody wants to ask something, then we can have these questions. Otherwise, we can close the session. So does anyone have any questions?
Perhaps I may make one last comment, perhaps before we take the last question. We would love to expand the study that we are doing to India. We're currently working with St. John's with Professor Dennis Xavier, whom you may know of. He's a very successful cardiovascular researcher to start the study in India. But if there are other institutions where this our study, a cohort study may be possible, we would certainly be open to speaking with you. Sorry to interrupt.
Yeah. So I think a wonderful opportunity for all of us. Yes, Dr. Shivaji Basu is one of the senior urologists of India, and Dr. Shivaji Basu wants to ask a question, sir.
It may not be that pertinent for this discussion particular, but as I got to learn, I wanted to ask you, do you see with a castrate level achieved by ADT and castrate level achieved by non-ADT, the cardiovascular symptoms will be same in both the groups, or you have gotten evidence that non-ADT treatments are much superior and in preventing cardio disease?
No,
in high risk group.
the evidence, I guess, is fairly limited because, as I said, surgical castration is certainly limited in North America. And the other thing we need to remember when you look at the data on surgical castration is it was primarily used some decades ago. And so at that time, the treatment of cardiovascular disease and risk factors arguably was much poorer than it is now. And so we can't even really compare apples with apples when we talk about comparing surgical castration with medical castration. And so essentially, I would treat these individuals the same, but in the absence of excellent data.
I meant to include the radical prostatectomy radiotherapy. That's sort of non-editing.
Apologies.
Sorry about that.
Yeah, I guess we're talking again though about some different populations. So the folks undergoing radical prostatectomy, in our experience, tend to be a little younger and a little healthier in general, obviously, to be offered surgery in the first place. But we don't have great data on their outcomes outside of administrative registries. So we, in our trial, still treat these patients similarly to people who are on hormonal therapy, for example. But I think we need to understand better the outcomes in patients who undergo prostatectomy as well. That's very important.
Dr. Ganesh Bakshi wants to ask a question. Sir, Dr. Bakshi, please go ahead, sir.
I am sorry, the hand raised was by mistake. I'm listening to the conversation.
Okay, I think Dr. Anuprita wants to ask a question. Please go ahead, ma'am.
Yeah, good evening. I would like to ask, like in our scenario, we like at the time of diagnosis, cardiovascular things are diagnosed. At the time of cancer diagnosis. Now that time when the patient comes, his glycosylated HB is uncontrolled, like about 9, his lipids are too high. And then there is the patient, from patient point of view, the clock is ticking. He wants to start. For him, one day is like the cancer is growing. So in that scenario, like how long to wait for optimization? Because what from my clinical experience, the patient who have baseline dyslipidemia, high glycosylated, either you give, whichever drug you give, which is best or less cardiotoxic, they'll land up into some other cardiotoxicity later, is my observation, rather than you go with a baseline high cardiovascular risk patient who has controlled lipid profile, and especially HbA1c and triglyceride, they do well, even getting a cardiotoxic chemotherapy. So for optimization, because we generally deem them high risk and ask them to go ahead with close monitoring, but still at one stage, they have to have got interruption in the treatment due to risk the thing. So how long you would generally advise this patient for optimization, or you immediately would suggest to start?
I think we're in a fortunate situation where we can see our patients in a dedicated cardio-oncology setting fairly quickly. So for us, it's, it's a bit of a moot point or an academic question, because we can usually implement both the cancer treatment and cardiovascular treatments simultaneously, essentially. And that's obviously ideal if you can start both at once. If that is not possible for resource reasons, then I don't think you necessarily need to wait until your lipids and HbA1c are well controlled to start the specific therapies. Obviously, it's highly desirable, but and it depends a little on the clinical circumstances, right? So, for example, someone whose PSA is only very slowly rising, that might be something that can be taken more time with. Whereas someone with metastatic disease and threatened cord compression, etc., clearly they need to start their hormonal therapy as soon as possible, and probably there with an antagonist, as you know.
Dr. Shailendra Shakya also wants to ask a question. Dr. Shailendra Shakya is cardio-oncologist and the cardiologist working in Nepal.
So my question is, Dr. Avirup mentioned earlier that he would get a CT score in some of the patients. My question to Dr. Leong is, how often do you practice getting this calcium score before starting a patient on these therapies?
Yeah, it's a great question. I think that availability, accessibility of coronary calcium perhaps differs a little bit in the United States compared to Canada. So we tend not to get many coronary calciums, I have to say. We may, of course, use the poor person's coronary calcium if they've had CT scans, just looking for sort of qualitatively evidence of arterial calcification there as a surrogate. But we generally treat on, I guess, the clinical risk factors we have available without sort of dedicated further imaging, unless, of course, they have cardiovascular symptoms or are particularly at high risk, and we will undertake imaging for specific conditions like that.
Okay.
Yeah.
Thank you.
Dr. R.K. Gopalakrishnan also wants to ask. Sir, please go ahead, sir.
Yeah, well, I would probably end this session on a philosophical note. In the past, we have seen patients with advanced metastatic prostate cancer who have been on ADT for many years, dying of cardiac events or of cerebrovascular events. And we used to probably philosophically think that it was a kinder end to the person and the disease. But now I think we are wiser in knowing that these are also preventable. And I think we will still be able to prolong the life of the patient with the present knowledge. So that is my small little take on this.
Yeah. Thank you, sir. I think, with this wonderful note, I would thank Dr. Darryl Leong once again for joining us. And I would thank all the panelists, the speakers and the chairpersons for joining us for this ACOS meeting. This was a really successful meeting. And after a long time, we started again with our Asian Cardio-Oncology series. And we hope to continue meeting every month to discuss some of the other cardio-oncology issue. So with this note, I would say good night to all of you and thank you.